Oh, wait. Check. Check, check. Check. Check, check. Check. Oh, okay. Oh, Heilish also can see it from home. We'll text them. We'll text them. Yeah. Oh, let me put the mic down. Check, check, check.
We're on.
Both has to be blue and green on.
Yep.
Good.
Cool.
Yes, I thought the green was supposed to mute the. The boss is
You ready?
telling me what to do.
Okay. Do you want to put her
No,
slides
this is
here?
my
Or she's
son.
going to sit here, or
That's my son.
okay. Perfect. Yeah. Okay.
No.
All right.
I have to. My son and my daughter. So people in the kitchen should come up. They're like a bunch of them.
Okay. We go.
Oh, wait, I'm the...
Yeah. Okay. Beth, you ready? Okay.
We should, yeah.
Okay.
Yeah, go ahead. We're not.
Good evening, everybody. Thanks so much for joining us today. We will go ahead and get started with our program. If everybody could have a seat, we would appreciate that. My name is Vicky Chang. I'm an infectious disease clinical fellow at the National Institutes of Health. And today I have the privilege of serving as your announcer. So I will be introducing the speakers for you and walking you through the program. First of all, I would like to extend a warm welcome on behalf of the Global Health Equity Partners Group to everybody for their generous support of tonight's dinner. We hope that through today's program, we'll be able to introduce you to a lot of our work, to share with you what we have planned in the works, as well as introduce you to different members of the team. And of course, we look forward to many opportunities to discuss our upcoming work with you and to incorporate all of your great ideas. I would like to extend special shout out to the team for organizing this beautiful event. So to start, I would like to welcome Dr. Bethlehem Atoma. Beth, right here, Dr. Atoma is a pulmonary and critical care medicine fellow at the University of Maryland and National Institutes of Health Joint Program. And she is the founder of the Global Health Equity Partners. Dr. Atoma is a passionate advocate for health equity. She is committed to expanding access to quality healthcare and medical education in underserved communities across the U.S., as well as in East Africa. And through her leadership, she works to strengthen health systems, empower healthcare professionals, and also develop sustainable solutions that improve lives and create lasting impact. So I would like you all to join me in welcoming Dr. Atoma to give her remarks. Thank you.
All right, thank you. All right, thank you all for coming. Thank you, Vicky. I think Vicky has traveled in a lot of countries that I have been, and I think I followed her to Uganda. She followed me to Ethiopia a couple times. So today, I'm kind of gonna give you the rundown of who Global Health Equity is. Turns out has a little bit relationship with who I am as a person. So born and raised in Addis Ababa. It's a center for some of you who don't know where Ethiopia is. And Addis Ababa is like right in the center. As most of you, it's a story of immigrant story. But one thing that I can say is I grew up with asthma, and so I kind of learned healthcare in a low resource setting at a young age. And so what I remember today is really the long lines, and not only that, to get to the clinic or the hospital, most of the time 2 a.m. when you have your asthma exacerbation, it is a pretty long distance that we had to get to go to the hospital. So distance and just a long line. Those are the two things that I remember. And you sit and wait, whether it's at midnight or during the day. And, I'm just assuming maybe that girl could have been me, right? Like, it looks like she's struggling to breathe. But that's kind of the flashback that I have. As any other kid, I grew up in a middle-income family, siblings of 5. But then right after high school, I made my way to Minnesota. Whoever is from Minnesota, shout out. Minnesota, I came in the middle of winter, so that was not fun because, again, I ended up in the emergency room multiple times, especially the first 3 months. So I would say it's not just the weather, it is the place that we stayed in. So you can see the mold is, I'm trying to like give you an example of what a mold looks like, but it's in the basement that we stayed. So my asthma was exacerbated frequently. But that did not really, the only thing that really brought to my attention was the difference in healthcare and how it is different to how I grew up. And after high school, I came to the US and I can see the difference. It was very instant. And I'm sure a lot of you who have traveled and migrated from a low resource settings, you know what I'm talking about. And so really, I saw this, and I know the emergency room still feels full here, very busy perhaps, but it's all perspective. But this is the thing that I saw. It's like healthcare is so different just because of where we were born. Again, I don't know if you can tell what that is, but it's a spacer. It's a device that helps you take the aerosolized medication directly into your lungs for asthma exacerbation, for example, right? The way they do it back home and other low resource settings, actually a bottle, they cut the top part and they use it as a spacer. So really there is a difference in healthcare and where you get the treatment, right? I mean, that is pretty obvious for those of you who've actually visited a low resource settings. But, got through that, went to nursing school actually worked as a ICU nurse for 7 years. But I also did a community college, got a full scholarship, and then continued to be at university. Graduated and made my way to working as a nurse. Throughout that time, I met my heroes. This is my husband, Ruby, respiratory therapist, my partner in crime. And then our 2 beautiful kids that are actually way grown up. They did visit Ethiopia a few times. They're heading there with us soon as well. This is Galu, who is, the IT person here, doing great. And then Mona is, where are you, Mona? She is the artist, so she's probably going to ask you to take her painting home today. She is amazing. Where are you, Mona? She's right in the back. We also don't want to forget, oh, by the way, that's how they act in the car. You can see, always have to make them stop fighting. And also our little dog, Pootie, was his favorite toy there. But I would say nursing kind of opened up a lot for me. It is to see the human need, be able to share people's suffering, whether that is in Ethiopia with asthma, a child with asthma, or it could be, unhoused person in Baltimore. People need care. And along the way, really what I'm going to tell you is that this is a teamwork, but it's just not, I'm not the only person. And I have a lot of people that I can point out, including Carla, who's the secretary. She did not make it today. Marty, who is treasurer. She's in the back right there, taking a picture. Kitty is somewhere there. She did nursing. Hi, Kitty. We are a team of people I have met so many people throughout my journey, including my fellow friend, Patton, who's here. Ruby, she's going to join us online. She's not feeling so well. My medical school friends. And also, these 2 kids that you see up there, their mom was dying of a breast cancer in Minnesota when I was a resident in a CIH, Center for International Health. And we almost adopted these kids, and now they're our kids. But all to say that I think our journey, hold on. And a lot of mentors. I have my program director there who did not make it today, but many people that I would want to mention that made this possible. And finally, I do want to mention there is somebody that I call my sister, closer than my sister, Tizo. I just want to say we love you. Sometimes you would think, you do a lot of things in life, and then there's always someone in the back that is carrying you, who's your backbone. And Tizo was that person, and she's hiding in the kitchen, I'm sure. And finally, I kind of want to wrap this up to make it short. Why am I telling you all this? Grow up with asthma, ended up being a pulmonary critical care, but now we have Global Health Equity Partner. I think it's a life journey, but at the end of the day, it is the love that I have learned as a child. This is my dad, who loves animals, but loves all people without any discrimination. And I think that is what is expected of us, is to love others, and with the gift that we have, right? There is a verse in the book of Matthew that says that the harvest is plentiful, the workers are few. We are the workers in the field that we're asked to do the job. And I think our part is to really respond to those calling that we all have. And today you're going to hear a lot of stories and a lot of things that has been happening in Global Health Care Partners, and we just want you to be a part of it. I also love animals, although even if I have to wear a mask because apparently I'm allergic to horse. And I never had beat my dad chess, and this is the first time I did. So I had to shake his hand. Thank you all. And I think Mona is warning you all, you better look at her painting. That's all. Thank you so much.
Thank you so much, Beth, for the remarks. I think it's a tremendous opportunity we have today to kind of learn the different stories that people bring. And I hope during the dinner later, you will engage with each of these team members, some of whom are presenting formally, but some of whom will just be wandering around. And I hope you will take the chance to chat with all of us and kind of learn our stories and share your thoughts. So with that, I think the team has prepared a brief video kind of talking about one of our main projects as part of the organization. As Beth mentioned, her training has been in pulmonary as well as critical care. And so with her personal experience as well as her training, this has been kind of the core of the organization's main focuses. And of course, we are developing new projects kind of as the organization grows. And so I'd like to share with you this video that focuses on some of our thoughts and work in the sector of critical care to kind of get you acquainted with some of our initial thoughts. Thanks. Oh, okay. Sorry, we're just pulling up the video real quick.
Hi, my name is Drivya Thoma, respiratory therapist and educator. I'm currently working at Children's National Hospital in Washington, D.C. One of the missions of Global Health Equity Partners is to educate healthcare workers in a low-resource setting. I have been honored to help train nurses and other healthcare workers in respiratory care in Ethiopia, including mechanical ventilation management, where respiratory therapy education is still limited.
ሱልጣን እባላለሁኝ። ያው እዚህ አዳማ ሆስፒታል ሜዲካል ኮሌጅ አይሲዩ ዲፓርትመንት ነርሲንግ ሄድ ነኝ።
ስሜ አስናቀ ደጀኔ ይባላል። ቤሲ ነርስ ነኝ። የማገለግለው ያው በአዳማ ሆስፒታል ሜዲካል ኮሌጅ አይሲዩ ዲፓርትመንት በአሁን ጊዜ እየሰራው ነው ማለት ነው። ትሬኒንግ ኦን ሳይት በሆነ አካል ተዘጋጅቶ እዚሁ ለ5 ቀን ወስጃለሁ። ያ በጣም አሪፍ ነው፣ ለውጦኛል። አይሲዩ ምንድነው ከሚለው ጀምሮ ከሴታፑ ጀምሮ ከዛ እንደውም ኢቭን ትሬኒንጉ በጣም አድቫንስድ ነበር። የማሽኑን ዲቴይል ነገር ሁሉ ነበረ። ሲያሰለጥኑ የነበሩትም ከፍተኛ ባለሙያዎች ናቸው። ሪስፓይራቶሪ ቴራፒስት ስለነበሩ በጣም ጥሩ ትሬኒንግ ነበር። እኔ ለውጦኛል። ከዛ በኋላም በዛ ትሬኒንግ አይደለም ሞጁሉ ስለነበር በየጊዜው በቸገረኝ ቦታ ቅድም እንዳልኩሽ ነው ያንን ሞጁል በማንበብ ሁለተኛ ደግሞ ሲኒየር የሆኑ ስታፎችን በመረጋገዝ በመተጋገዝ እና በጣም ጠቅሞኛል።
ስሜ አራርሳ ደሳለኝ ይባላል። ዲፓርትመንት የቢኤስሲ ነርስ ነኝ። አይሲዩ ነው የምሰራው። 3 አመት ሰርቻለሁ። አው ትሬኒንግ ወስደናል። ኖርማሊ አድቫንስድ ላይ ወስደናል። ባለፈው ቤቲ ምናምን ተሰጥቶን ነበር፣ ግን በቂ አይደለም። ኖርማሊ 1 ሳምንት አካባቢ ነው የወሰን፣ ግን ብዙም ናውሌጅ አገኝተናል። ለፔሸንትም ፔሸንት ኬርም ጥሩ ነበረ፣ ግን በቂ አይደለም። ኖርማሊ አገኝተናል። ሌሎች በሮቴሽን የሚገቡም አሉ፣ ለነሱም ትሬኒንግ እየሰጠን ነው። ኖርማሊ ግን በቂ አይደለም። ትሬኒንግ ያስፈልገናል። አሁን አዲሽናል ትሬኒንግ ካለ ኖርማሊ
በሮቴሽን ሰዎች በየጊዜው ስለሚቀያየሩ የተለያዩ ስልጠናዎች ቢሰጡ አሁንም አይሲዩ ቤዚክ አይሲዩ ትሬኒንጎች በተጨማሪ ቢሰጡ ሞር ከዚህ በላይ ሰዎች ማነቃቃትን ይፈጥራል፣ ፕላስ ደግሞ ጥሩ ለውጥ ያመጣል ብዬ አስባለሁ።
እንደዛ አይነት ትሬኒንጎች መቀጠል አለባቸው ባይ ነኝ። ስፔሻሊ ሰው እንደመጣ ስራ ከሚገባ ቢሰለጥን በጣም ጥሩ ነው፣ ግን በቂ አይደለም። ትሬኒንግ ጋፕ አለ። አብዛኛው ስታፍ በሮቴሽንም ይሁን በመደባም ይሁን የሚመጣው ዊዛውት ኤኒ ትሬኒንግ ነው ማለት ነው። ስለዚህ እዚሁ ኦን ጆብ ትሬኒንግ ነው እሱ የሚወስደው። ከኔም ጀምሮ እንደዛ ነው ያለው ትሬንድ። ከሌላ ቦታ ትራንስፈር መጣው ጋፕ የነበረው እኔም ኢንተረስትድ በሆንም አይሲዩ ነው። አይሲዩ መጣው። ከዛ በኋላ ትሬኒንጉ ብዙም የለም። አይ ቲንክ ኦን ሳይት ትሬኒንግ አንዴ ተሰጥቶናል። ያ ነገር ብዙ ለውጦኛል እኔም ፐርሰናሊ ማለት ነው። እኔ ለውጠኝ ማለት የፔሸንቱን ኬር ነው የሚለውጠውና በዛ ሳይድ ጋፖች አሉ።
ላለም ታከለ ባላለው ሲኒየር አይሲዩ ስታፍ ምን እኔ አሁን ቢጨመር ደስ የሚለኝ አንደኛ የነርስን ስኪል ከፍ ሊያደርጉ የሚችሉ ትሬኒንጎች ቢኖሩ፣ ከዛ ውጪ ደግሞ አሁን በአብዛኛው ነርሶች አይደለም እንግዲህ ያው ነርሲንግ ኬር ላይ ደግሞ የተሻለ አቅም ያላቸው ሰዎች ልምዳቸውንም ትሬኒንግ ቢሰጡ እሱ አሁን ያለንን አይሲዩ ትንሽ ከፍ ያደርገዋል ብዬ አስባለሁ።
አሁን እንዳነሳውልሽ ማቴሪያሎቹ ፉሊ ፈንክሽናል ካልሆኑ መስተጓጎል ይመጣል። ለምሳሌ ሊኬጅ ሊኖራቸው ይችላል። እነዚህ ሰርኪዩት የምንላቸው ሊኬጅ በመኖርበት ሰዓት ደግሞ ማሽኖች ፍሪኩዌንትሊ አላርም ያደርጋሉ። እነዛን ለመፍታት ደግሞ ሌላ ንጹህ የሆነ ሰርኪዩት ያስፈልግሻል። እነዚህ ስራ ማስተጓጎል ላይ በጣም ትልቅ ክፍተት ያመጣል ማለት ነው። ነርሶቹም በዛው ልክ ይቸገራሉ ማለት ነው። ለምን ፉሊ ፈንክሽናል ካልሆነ ማቴሪያል የሚያስፈልጉትን ነገሮች አቅራቦት የማያገኙ ከሆነ ትልቅ ችግር ሆኖ እየታየ ያለው ነው። ፕላስ ደግሞ እንደዛውም ነርሶች ጋም ያሉት አንዳንድ ጋፖች፣ ለምሳሌ ያልሰነጠሉት ነርሶች በየአመቱ ሮቴት ይደረጋሉ። አይሲዩ ያልሰነጠለ ነርስ ይመጣል። ያኔ ደግሞ ከማሽኖቹ ጋር ከሞኒተሮቹ ጋር ከአላርሞቹ ጋር ለማለማመድና እነዚህ ቬንቲሌተር ላይ ያለውን ፓራሜትሮች ሴት ማድረግ ላይ ብዙ ጊዜ ይወስድበታል ማለት ነው። ሌላ ሰው ሰፖርት እያደረገ በዛ አይነት መልክ የምንጠቀምበት ጊዜዎች ስላሉ ትልቅ ክፍተት አለ ብዬ አስባለሁ።
Today, we have expanded this training support to the country's only respiratory therapy program. And our hope is to continue building sustainable education that strengthens frontline healthcare workers and improve patient care for communities in need.
My name is Adam Getaon, and I'm an intensivist and department head of intensive care medicine.
I am Dr. Mahlit Mutuku. I am an assistant professor of internal medicine, and I'm a second-year fellow in our department of intensive care medicine. During our fellowship trainings, we receive, it starts from the basics of like airway management, including difficult airways and the like. And we also receive trainings on the basics of like physiology and anatomy of our patients. Not just that, like we're trained with procedures like inserting lines like central lines or arterial lines, including chest tube insertions as needed, and putting and managing patients on mechanical ventilators, as well as other life-saving, like in acutely life-threatening conditions as well.
As a hope, so these are the things that will give you a very huge hope. There are funders, there are donors, and there are volunteers who are like coming here and giving us some training and donating equipment what they are having at hand, and also facilitating some training for all the department and department members. So this thing will give you hope that one day we will have all the equipment and make our ICU very better.
But when we talk about quality of care, it's true that we have the facility and like the trainings as well, and the trainees, including the fellows like us. So we would have been able to utilize this manpower if we had been better trained. I believe it would have resulted in a lesser mortality and also lesser morbidity, and also it would have been, I would say, more evidence-based. As you know, technology is like on the rise these days. You can do almost anything. And that all comes down to actually helping the patients to have a better outcome and to have a better quality of life and standard of care as well. So due to those things, I believe it might make our care somehow suboptimal, because we don't actually have an evidence or an actual diagnosis sometimes to provide care for the patients.
I'm Dr. Kandalam Warko, an emergency critical care physician. I've served for the past 7 years at Hawassa University in the academic rank of assistant professor. And now currently I'm doing a fellowship in intensive care medicine at St. Paul Hospital Medical College. The training is more of hands-on training. At its nature, it's a subspecialty training. So in hands-on training, there are some equipments which are lacking, and not the equipments per se, there is also a lack in training.
I'm Ruby Simisalam. I'm a physician trained in neurology and critical care. I have a master's in public health with a focus in health community sciences. I've been doing work with local communities, both in the United States and globally in Africa, Ecuador, and Asia, working with communities to develop tailored health programs. I have found this work to be really rewardful, to be able to partner with community members, community leaders, figure out exactly what sort of gaps in medical care they have, and develop a program to improve access to care, as well as providing medical care directly. The thing that has been most impactful is to be able to see a program develop. So to start at the beginning with community leaders, to do a needs assessment, to then develop a program for the specific community, and to see that roll out, and to see hundreds of people be able to access care that they never would have been able to previously. I joined Global Health Equity Partners because of its history of partnering with low-resource communities and expanding medical care through sustainable ways.
Thank you. So next, I would like to introduce Bill Letourneau. You may have seen Bill in the video earlier. So Bill comes to us from Minnesota. He actually, this is his third trip in a row for the past several weeks that he took the time to come here from Minnesota to share some of his experiences with the program with you. Bill has been a respiratory therapist for more than 30 years. And he has been at the Mayo Clinic in Rochester, Minnesota for the last 12 years, where he served as a clinical educator. His research interests include mechanical ventilation and lung protective ventilation. He is also active in the American Association for Respiratory Care, as well as the American Thoracic Society, at which professional conference he was just at a couple weeks ago as well with Dr. Atoma. And in his spare time, he enjoys traveling with his wife, Dee, who is also joining us here today as well. So we are privileged to have him join us and share some experiences.
All right, well, thank you for having me here. This is, when Beth asked me to come here and do this, it was a little out of my norm. I usually talk or give presentations on pulmonary mechanics and lung protective ventilation, which of course is sedation by PowerPoint. But this will be hopefully a little more personal and have a little bit more information about Beth's really excellent project. I was able to accompany them to Ethiopia, like I said, July of 2023. Again, I think that the Global Health Equity Partners idea was just kind of in its infancy, and Beth has really moved it along. So she asked me to come and present here, and I thought, well, what would be the theme of this? What would be the theme of this talk? If I'm not talking something technical about mechanical ventilation, what am I going to talk about? Well, I really started to think about the theme here, and the theme was really, it started in an exercise of trust. Because I was, when I was on social media, I was on LinkedIn, and I got a direct message from someone that I'd never met before, asking me to participate in a project that I wasn't really sure of. I didn't know what was going on. But I took the leap and I actually replied to the direct message. And as it turns out, Beth was married to Derby, and Derby was a former student of mine. So I'm like, okay, this sounds good. This sounds legit. I'm going to move forward with this. We subsequently had a Zoom meeting kind of talking about the project, and it really brought me more into the fold and what was going on. And interesting enough, about 2 weeks after the Zoom meeting, I was heading to, it was San Francisco. Sitting in my seat on the plane, and coming down the aisle in the plane is Beth. And I'm like, what a coincidence. I mean, this was meant to be, that we were going to do this. So then we had lunch later in San Francisco and talked a little bit more about this. So now you're probably wondering, well, what about this picture? What does it have to do with trust? They did ask me, they say, hey, can you take 2 bags? And I'm like, yeah, I've got my bag. And they say, we'll have a bag full of supplies that you can take with you. And we'll actually have it delivered to a cousin or something in Rochester. You can go pick it up, and then you can bring that with you. So I go and pick it up, and that bag doesn't do it justice. It was probably this high, and it weighed, I think it weighed over 50 pounds. It was over the max. I unzipped it, looked in it, it was packed with supplies. And I'm like, well, there's no way I'm going to unpack this thing to see what's actually in this bag. I mean, it could have been just about anything in this bag. And I didn't want to spend a lot of time in prison because of this project. So I just took it and I checked it. And getting on the plane, there were 2 customs agents standing right at the jet bridge. And I'm like, well, that's it. Here we go. But they let me through. So I'm like, okay, but that wasn't the end of the story on that bag either. I got it, and I'm so happy that Derby met me at the baggage claim in Addis Ababa, and he pretty much took possession of that bag. And what did it take? 3 hours to get that bag through customs? And he really did a nice job working that bag. So here's the first picture of us in the back of a van in Ethiopia heading to Adama, and there we are. And I think that bag might be in the back there. But again, trusting someone to get us to Adama, and they did. And Adama was a really nice place to visit. I mean, this is actually a picture out the back of my hotel room. So we spent about 2 weeks there, and it was really fun. There was also another part of the trip where I met up with a few more uniformed men, and this was on the floor of my hotel room. We showed up one day after working at the hospital, and there was a number of vehicles, a number of uniformed and non-uniformed, very official-looking personnel at this hotel. So someone very important must have been staying there. And they did really look me up and down every time I headed to my room, because they had a little spot right up on that second floor. And they were there. They were there watching us, and I stuck out like a sore thumb. But they let me be for the most part. So one of the most trustful events that happened on this trip was we were at about a week in Adama, and we were going to head over to Addis, and I think we were going to Derby, I think your uncle's house, to stay with him for the weekend. And he came and picked us up, and the most interesting thing happened. We were on a freeway heading towards Addis, and there was an accident up ahead. Closed the road, which is, that's a major deal here. You're going to be stuck there for a while. Over there, they turn around or find a way over to the other side of the road, oncoming traffic, and make a lane going against traffic. And basically, here we are. And again, it wasn't Derby driving, it was his uncle. But we're driving on the wrong side of the road, oncoming traffic. And I think Beth kind of tapped me on the shoulder at one point and said, "Hey, are you okay up there?" Because I'm in the front, they're in the back. I said, as long as we're not the first car in this train, I'm okay. And we got past the accident and bopped off, and everything was fine. Derby's uncle did a great job of getting us there, driving through. So we did make it to Addis. There's about 6 million people there, and I believe on that day we saw all 6 million of them trying to get to where we were going and where we were getting to. Maybe one more slide on trust. Derby did drive. Wasn't just his uncle. He was behind the wheel for a lot of this trip when we were in the capital there, and it wasn't always, it wasn't always a calm trip. It's not true. He did a really good job. He got us where we needed to go. And again, this isn't completely accurate either. Beth was in the back. I was in the front. So they always made me sit up in the front there. But he did a great job getting us around. If you think a roundabout is challenging here, roundabouts in this capital, they may be 4 lanes, but I guarantee you there is at least 7 lanes of traffic going through this roundabout. And Derby really did a nice job of, he probably remembered or he fell into the rhythm of it, because there's a rhythm to the horn honking. Right? And it's not always aggressive, it's not nasty. A little beep, just, I'm on your tail. Back left, here I am. A little longer beep, I'm coming up on your left. And a little harder beep, you're a little too close, move over. And I got the rhythm of it. I saw it. It was very interesting. So we went to Addis Ababa, and I told them when I first got there, don't treat me like a tourist. There's only one thing I want to see when I'm here. And I said, I want to see Lucy. And I'm not sure if you knew what I was talking about, but I want to see Lucy. And they're like, okay, we can do that. So we went to the National Museum of Ethiopia. And if you don't know, Lucy is one of the oldest, they may have found someone older, but one of the oldest kind of human skeletons, Homo erectus, and I don't know, 50 birr, and I don't remember the conversion, a couple of dollars is all it took to go to this museum and see Lucy. So there I am with her. So that was kind of a really nice highlight. Another thing that I really enjoyed about going there was I'm a big birder. I love birds. And so I decided I'm going to, I think it might have been a gift from me. Someone gave me a gift of the birds of the Horn of Africa. And when I was looking at this, I saw the red-cheeked cordon bleu in the book. And I said, I got to see this bird while I'm there. And of course I did. That photo on the right there is my photo. And I think by the end of it, Beth and Derby started getting an appreciation for the variety of birds that were there the whole time, but maybe they didn't quite appreciate it as much because they're so used to it. So that was kind of the human part and the fun part of the trip. The actual objective of the trip was mechanical ventilation education. And this is where Beth really trusted me to kind of help them out with constructing and developing this mechanical ventilation program. So there's a lot of gaps, of course, in mechanical ventilation, and the nurses were teaching, or were really what we're running the vent or managing the ventilators without real formal training, without a lot of exposure and experience to it. But we tried. We worked with them, and we got to the meat of it to see if we could help with some of this. I did take one picture, and I kind of purposely took this picture on the left. This is kind of the top, the leading causes of admission and the leading causes of death, and that's on the left. And I partnered that with the same time period, 2015, of the United States common causes of ICU admission and ICU death conditions. They're relatively the same. So when it comes right down to it, they're not met with an insurmountable challenge there. They're really met with the same challenges that we have all across the world. We just need to be able to outfit them with the knowledge, with the experience, with the exposure to manage these vents. So I think in one of these slides it might even say here, there's an 80% mortality for patients on ventilators out there, or ICU patients. And we saw that on our 2-week visit there. There was not a lot of patients that survived being put on a ventilator for a number of reasons. Not necessarily the care they were getting when they got to the ICU. A lot of it may have been, part of a pre-admission issue with that, but it's not insurmountable. They can do it. Team members here, I think we saw this picture already. Some of the methods of what Beth is trying to do there, getting an idea of what they need, putting together some curriculum, and getting to see them and give them some testing and do some things. And that's part of that mechanical ventilation low resource setting curriculum that we made. And they saw that before we got there, so they were prepared for the questions that we gave. And management training. When we got there, I don't think everyone who signed up for the training was there and in person and around the vent and around the ICU beds, but we noticed there was a lot of other people trickling in as the days went by who were hearing about what we were doing, and they were coming to see what was going on and what knowledge they could bring from it as well. So we did that pre and post training, and this is one of these radar plots that it's kind of the sedation by PowerPoint kind of slide here. But really this just showed that middle blue line is where they were scoring on the pre-tests on week 1 and week 2 groups, and then the red line is that post-training group. So they're really improving on their scores by the end of a 2-week training. This was one success story, and I don't know if Derby, if you remember this one. This was a pediatric patient over in the corner, and they actually did pretty well. I can't remember if it was a neuro thing or a motor vehicle accident or both, maybe. But this one actually did well, and they were able to leave the ICU off the ventilator. So we were pretty happy with that. This one right here, I think was the last morning that we were there. I think Beth and Derby stayed a little bit longer, but I was off to the airport that day. And I just really support this program. I think it's a meaningful program, very useful program, and it is needed. right? From my perspective of respiratory therapist and mechanical ventilation, I'm very passionate about the education portion of that, about the implementation of mechanical ventilation, and anything I can do to help, I'm always ready to help with that. And by the way, after we did this, after the visit, we actually did for about a year or so after, we did some virtual vent rounds, where it'd be 9 o'clock Saturday morning for me. I would log on, it's probably 5 o'clock in the evening for them, and we do some virtual vent rounds. They would just bring a phone around and we would talk about these patients individually. So we had a little bit of follow-up as well. So I really appreciate the invite and really appreciate the effort you're doing with this. So thank you, Beth. Thank you, everybody.
Thank you, Bill, for that hilarious and insightful talk. I think it's been really wonderful to see how this program has evolved. To give you a little background, I think, when Beth started residency, she had already been thinking about, the whole point of her medical training was how could she make the care better in Ethiopia and in other underserved areas. And so she had already been thinking about that. But during the first part of our residency, there was the pandemic, we were going through intern year, and then there were some administrative reasons where she was not able to go to Ethiopia. And so she really did not make it to Ethiopia until our third year of residency. But I think what has been really striking is kind of the partnerships that she very quickly developed. You can see, all the people that are involved in this work, including many of the people who are here, that has been, through these many years of kind of sometimes very deliberate and a little sketchy kind of networking, but to a great cause. And I think that has been one of the great strengths in bringing together all this expertise. And it's been really great to see also people donating their time and other resources as well, including, for example, Bill mentioned doing these rounds during other times, making these very long trips to other areas where we are often unfamiliar, and that has been a great learning experience for everybody. So with that, I think I will stop talking, and I'm sure everybody has smelled the excellent food that has been prepared. So we would like to start our dinner service. It will be a buffet-style dinner, so please feel free to grab a plate and have the food that speaks to you. We have labeled the food that's vegetarian, and so if anybody would like to have only vegetarian food, hopefully that's clear to you. Also, I believe all the food is gluten-free as well and freshly made. We also have samosas, cookies, and coffee as well, and later there will be a coffee service as well. So with that, please enjoy. We will welcome you back to the program after you've enjoyed your dinner. Thank you. Nice job.
extra 5 minutes of history.
Yeah.
continue with our program, but please continue to enjoy your dinner. I will go ahead and introduce our next speaker, Dr. Ruby Sima Salam. We saw her earlier in one of the videos. Unfortunately, she's feeling sick today and so was unable to make it in person. But I will do a brief introduction and we will play this video that she has prepared for us regarding her presentation today. And so Dr. Ruby Sima Salam is a neurocritical care fellow at the University of Maryland. And she serves as the Director of Strategic Alliance as part of the Global Health Equity Partners. She has significant passion for health equity as well as community-centered care. And her prior work has spanned public health initiatives, global medical education, as well as sustainable healthcare partnerships, both locally as well as internationally. And what sets her apart is her ability to combine clinical excellence with deep compassion and a genuine commitment to uplifting underserved communities. And I think she spoke to that earlier in the video that we've seen. She will very soon begin an exciting new role at the Tri-Health as an attending physician and continuing her mission to advance equitable and impactful care. And so with that, I will turn it over to the slide presentation, which I believe she has prepared a video presentation for. And again, I invite you to continue enjoying the wonderful dinner. Thank you.
Low and middle income countries bear the greatest burden of critical illness globally, yet have the fewest resources to manage it. It is estimated that 8.6 million premature deaths occur with critical conditions, and up to 80% experience health-related suffering. 70% fail to receive access to critical care, and up to 100% mortality rates depending on critical care diagnoses and the region of the world the patient is located. Factors that are impacting the global burden of critical illness include critically ill young patients, as well as the rising aging patients. The urban concentration of the ability to provide critical care creates extreme geographic access inequity for rural populations. There is also a huge research gap as most critical care evidence originates from high-income countries, misrepresenting the global population as at risk for critical care-related illness. There is significant disparity in ICU bed availability across the globe. On average, high-income countries have 22 ICU beds per 100,000 population people, but in low-income countries, on average, this is 1. As you can see in Ethiopia, it's even less, with 0.3 beds available per 100,000 people. There are many systemic barriers to access to critical care in low and middle income countries, including geographic inequity, financial barriers, health system fragmentation, and infrastructure gaps. ICUs are typically located in urban hospital systems. Rural patients have to travel hours if they're able to survive to reach ICU care. Distance and transport are primarily mortality predictors in sub-Saharan Africa. Only 30% of patients reach ICU within 24 hours in a study done in Rwanda. ICU care is expensive. Many governments allocate less than 5% of GDP to healthcare, leading to high out-of-pocket costs, rationing of supplies, and early discharge. No standardized triage protocols and fragmented referral systems lead to delays in care. Lastly, unreliable electricity and oxygen supply, limited laboratory and imaging are common and make ICU care challenging and incomplete. Workforce and staffing gaps also contribute to inability to provide efficacious critical care. Compared to high-income countries, low and middle-income countries rarely have intensivists, nurses with critical care training, and nurses typically have a ratio of 1 to 5 or greater, and manage mechanical ventilation without appropriate treatment. There's minimal availability of respiratory therapists, pharmacists, and rehab specialists, all of which contribute to poor critical care outcomes. Common ICU admission diagnoses in low and middle income countries are the following.
Do you know what that doctor said?
Trauma and
The
TBI,
remark
post-operative respiratory failure, and obstetric emergencies. These are distinct and different from high-income countries where we predominantly have cardiovascular and respiratory.
He's leaning on his hand.
I see mortality
the
is
table behind us.
significantly higher
You see
in
it?
low
Yeah.
and middle-income countries.
What, behind the
such as
green lady?
Haiti.
Okay.
As you can see, in sub-Saharan Africa
Yeah.
and Ethiopia and other associated countries,
Yes.
mortality is as high as 55% in Ethiopia, compared to 8 to 10% in high-income countries such as Germany and the United States. In low and middle income countries, less than 50% of critically ill patients survive to discharge.
I have the photo.
Common causes for ICU mortality in low and middle income
This is
countries
a guy.
include
He
sepsis,
is a
traumatic brain
realtor, the white
injury,
coat. The white coat.
nociceptive infections,
He's
including
drinking right there.
ventilator-associated
Did you see?
pneumonia,
Yeah.
respiratory
You just had
failure,
a drink.
multi-organ
Yep. He is a
dysfunction, and
relative.
cardiovascular
Okay.
failure.
What is his name?
Many of
F4.
these causes
Thank you.
are
F4 for sponsor. He's like gold sponsor. The strong gold sponsor. Moya restaurant, they're not here. Mulu Fest, the samosa.
There are several limitations in critical care delivery
Audamet Market, Nazareth Market.
First, I shall highlight
They donate the food.
Yep.
Is there anybody else?
This includes mechanical ventilators, invasive monitoring with measured blood pressure, second kidney replacement therapy, doing ultrasounds, blood cultures, microbiology, and more invasive neuromuscular monitoring are all very limited in low and middle income countries. Our intervention is to target mechanical ventilators in making ventilators more accessible and teaching nurses who manage the ventilators how to prevent ventilator-associated lung injuries. Other limitations include medication and pharmacology access and gaps, lack of protocols and guideline implementation, gaps in training and knowledge, and a lack of an infection prevention and control program. Next, I'll address some proven interventions that can help close some of the outcome gaps in low and middle income countries. Quality improvement evidence that's been shown to be successful include ICU vital signs protocols in Tanzania, Dr. Toma's mechanical ventilation training with nurses that they presented on, sepsis bundle in Brazil, focused training to improve emergency recognition of different causes of decompensation in Rwanda, and a surgical checklist that's been adapted in multiple low and middle income countries. As you can see, education alone, feedback alone, protocols alone don't have the same level of improvement in terms of process and outcome measures as a combination package that involves protocols, education, audit, and feedback. The path forward for improving access to global critical care and improving equity involves workforce development, infrastructure investment, protocol standardization, and increased research and evidence generation. Our intervention is to target mechanical ventilation education. The evidence from Dr. Choma's prior studies showed that there is 80% mortality related to mechanical ventilation in Ethiopia. 88% of daily mechanical ventilation caregivers have no formal mechanical ventilation training, and 85% reported the need for more training. We know that unrecognized dyssynchrony, inappropriate tidal volumes, poor ventilator-associated bundle adherence, and no structured weaning all lead to ventilator-associated injury, which can prolong ventilation and multi-organ failure. We will be working with medical fellows at St. Paul's Hospital in Addis Ababa. There will be 2 parts to our intervention, the first part of which is currently occurring, involving online modules where we meet weekly on an interactive video session, going through different chapters addressing ventilator physiology and synchrony. The second part will occur this summer when we travel to Ethiopia to do on-site hands-on training, including bedside teaching, simulation, case studies, and a knowledge assessment. This program has been done already in the past, where 4 fellows were enrolled. Our data regarding their knowledge pre and post assessment will be coming, and this is the second year where we have 6 current fellows enrolled. In summary, there are significant health disparities related to critical care access and quality in low and middle income countries. There are many barriers and potential for intervention, as we've discussed today. I hope, with the help of GHEP, to address the health inequity related to mechanical ventilation in Ethiopia through mechanical ventilation education and integration of protocols adapted to the local culture and resource availability. In the future, I hope to expand what we are doing to include neurocritical care, and we thank you for your support and hope that you will continue supporting us through our journey.
I apologize again that Ruby was not able to join us today, but very excitingly, she will be part of this next trip the group is planning to Ethiopia this summer, and to put a lot of these continuing interventions into place. With that, I would like to just very quickly acknowledge our sponsors for our event today. Those, of course, include yourselves being here today and your support. We really appreciate that. In addition, I want to acknowledge many of the restaurants that very generously donated the delicious food that we had today, as well as additional financial support. I will acknowledge our gold sponsors. That includes EFOI Properties, LLC. That is a realtor. And in addition, we have several restaurants, including Moya Restaurant, that is also a gold sponsor. Our community sponsors, these include Mulu Fest, I apologize, and then Damet Market. And then in addition, our supporter sponsors include Nazret, Al Jazeera Restaurant, and Gocha, as well as Mieza Restaurant. Apologies about the pronunciation. And I will just mention, one thing that struck Beth and I and several members of the team is the warm community that exists at the DMV. We were just at a restaurant this week in Silver Spring talking over some of the planning for these events, and we just ran into people who were interested in the project, and we started talking. And we have people like Beth's hairdresser who's here helping us with the coffee ceremony. And so I think this is really heartwarming to see a community come together for a common cause. And again, we really appreciate both the individual as well as the organizational sponsors for your support of this project. And we hope we're able to show you what we plan to do with your support. So thank you. So with that, I would like to move forward with the program. And now I will invite Dr. Seife Johannes to share some remarks regarding his experience. So Dr. Seife Johannes is an associate professor of medicine at Georgetown University. He is also the chair of the Department of Critical Care at MedStar Washington Hospital Center. He is an enthusiastic global health advocate, and he has been engaged in teaching, program development, and provision of care at hospitals in Ethiopia since 2012. So we are very honored to have his significant experience and to having here today in person to share with us a few remarks and his learnings. Thank you.
Thank you. Thank you. I get some gear. That's not me, but that's not me. I'm just gonna. Yeah, thank you. Thank you for being here. Really appreciate you coming out, and then thank you, the team that's putting this together, Beatty, Iman, and everybody else that's putting it together for such a successful event. The food was amazing. I think I'll go for another round. But so just a quick introduction about myself. Saifa Yohannes, I'm a critical care physician, and I did infectious disease and critical care. I'm the chair of the Department of Critical Care at Washington Hospital Center. And I started going to Ethiopia to support missions in 2010. And so over the last 15 years, it's just been a wonderful experience. And we've done multiple medical missions and education. And when I see somebody, especially fellows now who are motivated to go back and support, I can see, 15 years from now, their journey is going to be so amazing because the course of improvement of healthcare in Ethiopia is really improving. When I started in 2010, I started supporting because I gave a lecture on sepsis, and I talked about early antibiotics, and they told me, well, there's no pharmacy, the patients cannot afford the medicine, so giving antibiotics in 3 hours, right? And we say every hour delay in antibiotics increases somebody's chance of death by 8%, right? That I thought was one point that I could teach, and I just said, if you don't do anything else, just get the antibiotic. This is not for the flu at home. This is for severely sick patients. But just get the antibiotic in. But they told me, but there's no pharmacy. The medicines are expensive. They have to go and collect money from family to raise. So that was an eye opener. And I from that journey, so I worked into many things, including fundraising for hospitals. And then we're still doing, I still go 3-4 times to Ethiopia. We just went last October and taught the SIVA course, Cleveland Clinic's mechanical ventilation course in Ethiopia. And we will go back again in October to do that. And what you see is that, that saying, intelligence is distributed equally, but opportunity is not. So you go there and you are amazed how intelligent these doctors are, right? First, to get into medical school in Ethiopia, you have to be 0.001%. You're amazed at the intelligence of these people, but they just don't have resources. So if you can go and provide some of the education that this team is providing, you're nurturing a huge capacity of physicians who have so much knowledge, so much hands-on experience. They just need that additional support, validation, knowledge that they can get. So I hope everybody supports. The other part that I think is not said enough is how things have improved over the last 15 years. Yes, the population has grown by 5x, so it's not adequate, but there's a significant improvement. Ethiopia's life expectancy in 2010 was 53, now we're up to 68, right? 13 years is no joke, right? The doctor to population ratio used to be one physician for 10,000 patients. Now we're up to about 3,000. In the US, about 300, sure. It's a long way to go, but the numbers are improving. We were just in Ethiopia in in February, doing neurosurgery cases. We took 4 neurosurgeons with my colleagues, Meraki and Dani, and there are 130 trained neurosurgeons in Ethiopia. And we asked the neurosurgeons that went from here, senior physicians, like, how do you rank our neurosurgeons? Do you see them as fellows, trainees, or equally your partners? They said, these guys, their hands are excellent, right? But the little equipment that we took, is what they needed, the little knowledge, the little validation. So it's really a rewarding experience. If you can go, I know there's donations and QR codes. I would start by saying it. Please donate and support this group. I really want to congratulate you, Betty and Durbe, and you know, I can see that this journey is going to be an exciting journey. It's going to feed more into you that you're going to feed into the country. It's going to create networks for you of people like this who are here, who see themselves as global citizens, right? And you know, we can't hide ourselves in a cocoon. We learned that from COVID, right? What happens in other part of the world affects us. We just saw what happens with hantavirus. We're looking at exactly what's happening with Ebola now, right? Whatever happens in another country helps us. And the training that was started by some of the diaspora physicians from the US to start critical care training in Ethiopia, and Iman was a part of that, is what saved the country during COVID, right? So mechanical ventilation was the most critical tool during the COVID pandemic. And because the critical care fellowship was started by diaspora physicians, with the support of diaspora physicians, those trainees pretty much saved the country, saved hundreds of lives. So I really want to say, sometimes you feel like you give, and it doesn't get better. But I'm here to tell you, you give, and it does get better. So please support. Thank you for being here. Thank you for having me speak, even though you forced me the last minute, but I appreciate it. Thank you. Thank you.
Thank you, Dr. Johannes, for those very meaningful remarks. I will add my personal experience, you know, visiting with physicians who work in East Africa. I remember one thing that struck me the first time I went to Uganda was the physicians there, they had to learn the guidelines, and then they had to learn what to do if whatever was recommended by the guidelines did not exist. And then they had to learn what to do if that also did not exist. And so for every medical problem that we had to learn, the physicians basically had to be innovative and learn not just the standard of care, but 2 additional sets of solutions to be able to treat their patients. And depending on the specific scenario that occurred that day, you know, they had to make those decisions. And so I think to echo what was just said, the lack of brightness is definitely, that does not exist. It's what kind of support can we provide to help people who are so bright and so dedicated really be able to provide the medical care that is needed. Also, I would invite everybody to grab seconds as well. So with that, I will introduce Dr. Iman Abdul Rahman, who will come and share additional insights with us. So as we've already alluded to, Dr. Iman Abdul Rahman is an emergency medicine physician at National Children's Hospital. She is an educator, global health collaborator, who advocates for children everywhere and is passionate about improving pediatric emergency and critical care in Ethiopia through research, education, as well as strong international partnerships. And we are grateful to have her with us today to share some remarks. Thank you.
How do I advance the slide? Great, thank you. This is how I advance. Okay. Yep. Oops. Okay. Go back. Okay.
Thanks everybody for being here. Thank you especially for being here despite the Arsenal and PSG games today. I was in the Skyline area in the DMV and everybody was watching that, and you guys chose to come here, so we really appreciate you guys for being here. I am going to be talking about pediatrics. Unfortunately, in Ethiopia as well as in the US, pediatrics is usually neglected, and as pediatricians we always have to advocate for children. And so my talk is going to be talking about the building of future pediatric emergency medicine and critical care in Ethiopia. And thank you for your attention. I also want to say that this work is being done every day by Ethiopian physicians, day and night. I was always kind of alarmed by like some of the physicians who get text messages about cases even when they're out, even when they're off. So their work is actually never done. They're always answering questions in the middle of the night for cases while the residents are taking care of children. So this work is being done every day by them. And so I am honored to be talking about, telling their story. Thank you. Just to reorient you guys, I know we've seen, this is my colleague's daughter who wants the attention. I think we should bring her over here. Let her speak. So we're going to be talking about Ethiopia. It is the second most populous country in Africa. Which is the most populous country in Africa? Nigeria, yes. We're second after Nigeria. And number 10 in the world. And did you guys know, like most African countries, about 47% of the population is children. So that's about 66 million children in Ethiopia right now. And out of 1,000 live births, 51 of those kids don't live past their 5th birthday. And that's 14 times more than high-income countries. And over half of those children die of preventable causes like diarrhea and things like that. Okay, so the slide went to the next page. So why am I working in Ethiopia? It's kind of, I'm Ethiopian. Seifa is actually my neighbor in Ethiopia. We grew up in the same neighborhood. But seriously, the reason is that there is a high burden of pediatric emergency medicine nationwide in the whole country. There's limited ICU access. It is growing. As Seifa said, there are changes, but it's still very limited in most places. There's delayed recognition and transfers of critically ill children. And the staff, there's unskilled staff. So there are no ICU training, and I'll talk more about that. This is the only graph I'm going to show you guys. And I just want you to look at the top line. It has the poorest billion. They have a lot of the blue, which is the non-communicable diseases, just like the high-income countries, but they also have the injuries, and they also have the communicable illnesses, the maternal and child health issues that Western countries and high-income countries don't have. And so the physicians in Ethiopia are dealing with triple burdens. And this is what it looks like in pictures. So you look at the top picture on the right or to the left of me, the car has turned over. How are they going to take that patient? Although we're building the EMS system, most of the time in the rural areas, which I also want to say, Addis Ababa is not Ethiopia. Ethiopia it's a whole country, and 80% of the population lives in the rural countries as well. So for the majority of Ethiopia, that's probably how they're going to transport the patients. And then, as Beth alluded, when you finally get to the emergency room, this is how crowded it is. And then when you finally make it to the room, there is very little resources. And that's the burden these 3 people were doing for years, until recently. Dr. Tigist, Dr. Mulu, and Dr. Marertu were the 3 pediatric emergency critical care trained physicians. I also want to say that Dr. Tashoma actually trained them. Oops, something turned off. Dr. Tashoma is a pediatric ER physician who helped the training of those 3 people. Okay, this thing is going without me. And that is a heavy burden for 3 people to carry for years. And they did that until recently. So in the last 2 years, the country started the first locally trained pediatric ER and critical care fellowship that was started in 2024 in St. Paul. And it was followed by a program in Black Lion in September 2025. The St. Paul program takes about 3 fellows a year. The Black Lion program is taking 2 this time, and hopefully with more resources, it will be able to take 3. And why do we need, what is the goal of pediatric emergency medicine? Okay, these slides are. So it's important to train future leaders in pediatric emergency and critical care. The Ministry of Health needs pediatricians to be advocating for that. As Safer may have noted, the emergency medicine field has grown tremendously since it started in 2008. But for the pediatric part, it really hasn't grown that much. And so that's why we need a lot of support in pediatrics. And actually, this is something that the Ministry of Health has actually acknowledged to me when I spoke with them. It's important that we have enough staff that can reduce preventable child deaths through life-saving emergency and ICU care. It's important to build sustainable expertise through education, mentorship, and team building. And again, I talked about the emergency system. At Children's National, we actually created a program called EMSC, where adult, EMS people know how to manage children. We need the same for Ethiopia. We always say in pediatrics, children are not little adults. So there are like intricacies that we need to like make sure that anybody that takes care of him understand. And so we need these trained people to be able to kind of sustain that field. And that was our goal. And so, the academic training for this fellowship includes case discussions, interactive lectures. We're also partnering with the Kenya program. The Kenya program was started about 3 or 4 years ago, and we're working together to kind of share some of the didactic lectures. We have a lot of international collaborators, which I'll talk about. We have simulation training to make sure that the physicians are ready whenever like this rare case of very sick child comes in. They know what to do first, what not to do. So we train them so that they are prepared when an actual patient arrives. There's journal appraisal. We talk about like what is the right thing to do, about different treatment methodologies, like what is important, what to avoid, what to do when. And then we also, there's also a morbidity, a mortality conference, and I actually attended one when I just returned 2 weeks ago, and there was one where they talked about a case that, it didn't end well, and so they were talking about what they could have done differently, and they took assignments on like what to do, like what to improve for those cases. So next I want to talk about the collaborators, which Dr. Tashoma is one. We actually created subgroups because the field is so big. We have a group that's working on simulation, a group that is teaching ultrasound and focusing on that. We have a research team that supports the research that's being done there. The resource mobilization, we still need to, that's the one where we need a lot of people, and I'm hoping like some of the Ethiopian diaspora, even non-physicians can help with that. We need a lot of help in that. I'm gonna go back. And then the nursing is the other one that is actually very big. There's a Global Health Institute in my hospital, and there's a couple of nurses that are helping, again, in pediatrics or in anywhere. I think, we're a team. Physicians don't just treat children. We treat them as a team. And so if we don't build the nursing team, then the care is compromised. And so we have support of the nursing team. We're kind of figuring out how to help the nursing team. And also the RT, which is exactly how me and Gerby got to speak to each other, because we're supporting the some RTs kind of reached out to us to say, like, how do we support, we need more education, and that's how this whole thing kind of came about, actually. This is a list of the collaborators from different universities, different children's hospitals that have been helping.
5 minutes.
Okay, this thing is moving too fast for me, but this, okay. I just want to tell you a case actually that one of the fellows told me recently when I went. And this one really blew my mind, and I thought I should share it with you guys. So he said he was rounding over the weekend, meaning like he was seeing all the different patients. And he said, he looked at this one kid and he said, "Yedek kamay maslan." And so that means he looked weak. So he decided, let me get my point of care ultrasound, which is like the same thing that you know, to look at, you know, when women have a baby, the same thing that they use for ultrasound. So point of care ultrasound is something that is kind of newer. Pediatricians, pediatric ER physicians and different front-end staff are learning to do that so we can diagnose things quickly. And in this case, it was an amazing thing because he actually looked at this kid's heart, and the heart was surrounded by fluid and was barely beating. And that's why this kid was yedekamo. Oh, that's why he was weak. And so this ability allowed him to mobilize a team to get the fluid out of the kid's, surrounding the fluid out of the kid's heart so the heart will beat well. And he told me that that kid actually came for a follow-up a couple of times. And this was 2 weeks ago. I mean, less than a month ago, he told me about that. So next, I want to tell you guys about the 3 fellows that just graduated in May. On that picture, you'll see Valence is actually from Rwanda. So he was trained, he was one of the 3 that was trained in the first batch of pediatric ER doctors. And he's going back to Rwanda, and he's going to help start the first pediatric ER and critical care fellowship there with another person that was trained from Kenya. The person right next to him is Dr. Tigis Bacha. She's the one that basically, I would say, sacrificed her whole life to try and get this program going. The other 2 people right next to her are the other 2 that graduated. Right next to her is Simret. She's from Tigray, and after she's graduated, and she's going to be, I'm not sure what she's going to do, but she's done, and she's in the country. And right next to her is Alkidan. Alkidan actually was just here at Kansas Mercy, learning the system here, and she was kind of calling me, telling me how amazing things are here, and she got a lot of ideas of how to improve things in Ethiopia. She was working at St. Peter before this fellowship, was very eager to make changes in Ethiopia, and now this fellowship has allowed her to go back to the same place, but better trained. And that's them during the graduation. It was a very happy occasion for them because this was a very grueling 2 years, nonstop taking care of sick kids day and night. And so their graduation, they were very happy. So what are the challenges? Why are we why am I here? The physicians in Ethiopia, and I don't know how much you guys know, they get paid very little. And so the monthly income is about 26,000 birr, which is about $162 a month. Now, if we ask people to come to this training and we don't give them any extra stipends, they can't live. It's just not even, it's not a luxury. They just can't do it. And the government, the local government hospitals don't have any budget for non-service education, meaning any education, any didactic lessons, anything that involves improving the patient care is not something that is covered. So they want the physicians to be working and giving service. That's the only thing they have money for. So that is very challenging, which is why a lot of Ethiopian physicians work in private clinics in addition to the local one. It's not a matter of greed or anything like that. It's a matter of survival. And so part of our fellowship is to try and give the stipend. So for at least for 2 years, they'll do the learning, to kind of improve how to take care of children in emergency and critical care settings, so that when they go back, they'll have this new found learning so that they can give better care. So I always think things are always an opportunity. I don't see things when I go to Ethiopia as a problem. I see it as an opportunity. So this fellowship success depends on us kind of supporting the education, and we need to invest in training, and that actually translates to improved care. And I always think, like, I have family in Ethiopia. I have like I have like cousins and their children. They all live in Ethiopia. What will happen if they have an emergency, right? Like, that's what I thought about even supporting Beth. My grandmother lives in Adama. If something happened to her, where's she gonna go? And so I always feel like it's kind of, even though we live here in the US, a lot of our family live in Ethiopia, and supporting them, it's almost like a must. That's how I see it. These are priority areas, and by the way, part of the presentation was it was kind of collaborative with the fellows in Ethiopia, so that I am making sure that I am kind of representing things the way they think, and what they find as a priority. And so this is a priority list that they gave me. First is international observership opportunities, because it's very hard. The resources in Ethiopia are very different. And so it's important for them to go and see what an actual ICU has and what it looks like and how to work in those settings. And so that was something that was very important for them. The stipend, I kind of elaborated about why that's important. Research is also important. I think somebody mentioned that a lot of the research that they're using is research from high-income countries. It just does not, it's just not that helpful because their setting is very different. So we need local research that kind of addresses the local needs. The point-of-care ultrasound, I kind of shared that story with you guys, the importance of that. So how can you help? Sponsor a fellow's training. Support the expansion of ultrasound and simulation-based training. Enable the international collaborators and observership opportunities, and support the research that is locally led. And a lot of that, there's no money for all of that. So lastly, I just want to say that every minute matters for children that are critically ill. It's important that somebody is ready to kind of rapidly do the right things to save a child. Trained pediatric emergency medicine fellows will build this life-saving expertise. One fellow actually will impact many thousand of children in their career. And your support will create this future educators, researchers, and national leaders. I also want to say one thing. We are not the first to help train pediatric subspecialists. There is an organization called ASLAN, which we used a lot of the lessons learned from them, and they trained pediatric oncologists. Now there's 35. This happened over a span of 12 years. And I've been going to Ethiopia since 2005 while I was a med student. I used to see how they used to put like paper on the wall to talk about like what oncology, like medicine, a child should get. And now when I went this time, I see those kids walking down this, they have the bald heads, their hair is all gone, and they're happy and they're healthy looking. I don't see the kids that have the deformed faces and all of that anymore because of all the training. And so I pray and I dream that pediatric ER will be the same. Like that in 10 years' time, we can actually say, we help train this and we can support the future of pediatric emergency and critical care. Thank you.
Thank you so much. I think it's clear from a lot of these sharings that this is a journey and it's going to take many years to get there, and it takes continual work. And so we're very grateful for those who have come before us and really, paved the way for a lot of this work. And then there are so many areas that we continue to work on. So with that, I want to take a break from the program and invite you to join us for our silent auction today. We had talked about this earlier. There are several cultural items from Ethiopia, as well as some beautiful artwork from Mona Atoma that we would invite you to take a look at. Great.
Presenter. That is very important.
I think it's okay.
I mean, I don't care. I'm just letting you know for the time that you guys have to do that.
Are they going to kick you out at 8?
They have it until 9.
Oh, okay. We could do him first and then the video.
But the video would kind of...
Kind of. Yeah, no, you can play the video first. I'm just letting you know.
We'll give them 5 minutes, yeah.
As long as they don't kick you out, that's all I want to do.
We will continue with the next part of our program. So, as we mentioned earlier, there are a few major focuses of our program. We had talked previously quite extensively about critical care, as well as additional topics, and now we would like to turn our attention to pulmonary care. And we will start with a video that will highlight some of our work in this area.
My name is Salamawit Tilahun. I'm a pulmonary and critical care physician, and I'm the head of the pulmonary and critical care division. Primarily, we work in inpatient, pulmonary inpatient, outpatient clinic, and we do procedures, bronchoscopy, and we handle also patients on medical HDU, also in the ICU and in other wards upon consultations. In our setting, so the clinical profile of the patients is different. The risk factor is different. Our setting is also a setting where infectious conditions are very common. Ethiopia is one of the TB high burden countries. So we have significant biomass exposure. And our patients usually present late. So these things make it unique. The biggest gaps mainly with advanced procedures, usually diagnostic as well as therapeutic procedures. So we don't have the equipment, as well as we lack the skills to do these procedures. So our fellows also lack training in these areas. Primarily in relation to bronchoscopy programs, we don't have endobronchial ultrasound, so we don't have EBUS. We lack forcepses, bronchoscopy forcepses, to do transbronchial as well as endobronchial biopsies. And for pleural interventions, we don't have enough equipment to do closed pleural biopsy as well as medical pleuroscopy. Early diagnosis, early treatment, as well as it significantly changes the overall patient outcome. So it affects specifically diagnostic and therapeutic modalities, as well as advanced options for patients in regard to palliative care as well. Recently, we encountered one patient who was referred from the regional hospital for an impression of unexplained pleural effusion. He had undergone chest tube drainage. He stayed there for more than a month, and when he came to us, already the effusion was complicated. Because we lack the equipment as well as the training, we could not offer him minimally invasive procedures for him. So we had to expose him for surgical intervention. So he had undergone VATS. Even if after the surgery, the lung failed to expand, so we couldn't again offer him further options of treatment. So there are multiple problems with this case. One of it is early referral, but a significant lack in case of training as well as equipment affected the overall patient outcome, and the patient was very young.
We are lacking some of the most basic resources or equipment, such as we don't have bronchoscopy in our critical care unit, and currently we don't have a fiber optic laryngoscope as well, which would come in handy both in diagnosing as well as managing difficult airways.
We don't have spirometry, so we don't do bedside spirometry testing. Bronchoscopy, we don't have bronchoscopy, so we don't do bedside bronchoscopy, and we have to transport the patient to bronchoscopy center to do bronchoscopy, even for intubated and mechanical ventilated patients.
It's our mandate, or it's actually in our curriculum, and it's in the need of critical training to receive the basics of bronchoscopy care. So bronchoscopy, as you know, it's used for both diagnosis and treatment purposes or therapeutic purposes as well. So because we lack this, there are times when we don't know what's actually going on with the patient because of the lack of bronchoscope. Also, there are some life-threatening conditions like massive hemoptysis or mucus plugs and the like that we're currently are unable to do because we lack bronchoscopy equipment. So those are some of the things. I would like to promise our donors that it would be handled very well. Once the equipment is here, there won't be any type of negligence or the like or misuse in any way. So by doing all this, I am sure we can impact, as I've mentioned before, we have patients from all sorts of backgrounds and from all over the country. So helping this ICU or helping this department per se does not just stay here. Not just that, if we're trained, if we have the better equipment, it won't stop with us. We will be able to propagate these things, because I know once we're trained, we can also train other fellows, other departments, other hospitals, even within our catchment or the like, and we can also provide that care, not just limited to this hospital, but I would say it would help nationwide as well.
My hope is, to make this institution a center of excellence for pulmonary services, where patients get adequate and optimal pulmonary service, where fellows are adequately trained. So in regard to skill, as well as leadership, research, that is my hope for the future.
Hello, my name is Patton Adderley. I am a pulmonary and critical care medicine fellow at the University of Maryland and the medical education lead with Global Health Equity Partners. I'm a proud Bahamian, born and raised, and I also completed medical school in the Caribbean, so I know firsthand the struggles that healthcare providers face in low-resource settings. As such, Global Health Equity Partners is a major fit for me. In terms of the medical education background of things, I've always had education in the forefront of my career. I was the academic chief resident as a resident at the University of Miami. I also was awarded the Dr. Talisa LaRocca Award for Medical Teaching, and I am the incoming academic chief fellow at the University of Maryland. I will take these skills and hopefully be able to impart invaluable knowledge to learners, adult learners across the diaspora, right now mainly in Ethiopia, but hopefully expanded to other low-resource settings. And I am just very proud to be a part of this organization.
Our last speaker for the night, Dr. Peyton Adderley. I will repeat a little bit his introduction in the video for you in case you didn't hear it clearly. Dr. Adderley is a pulmonary and critical care medicine fellow at the University of Maryland, where he currently serves as the academic chief fellow. This is not his first time serving as chief. A passionate educator and mentor, he previously served as an academic chief resident at the University of Miami. And he was honored with the Dr. Tulsa La Roca Resident Teacher Award for his dedication to medical education. At Global Health Equity Partners, Dr. Adderley leads pulmonary education initiatives, which we saw some descriptions in the video previously. And these initiatives focus on ventilator and bronchoscopy training, which are needed, and to try to expand access to high-quality respiratory care worldwide. His work reflects a deep commitment to advancing global critical care through education, innovation, and collaboration. And with that, I'd like to welcome him to share some remarks. Thank you.
Thank you all for having me. Thanks for that warm introduction. It's very weird to hear yourself talk. Didn't really like that. We good? Can you hear me now? Good. Okay. I know it's late and everyone's full, so I'll be fast. Oh, lost me.
Back on.
Okay. So obviously I met Beth in fellowship. I'm my co-fellow. And I'm born and raised in the Bahamas. I'm an island boy, Caribbean guy. My connection to Minnesota, I did go to St. John's University for undergrad. I was a Johnny, Collegeville. Many years ago, I vowed never to go back. The winters are brutal. I am just very proud to be a part of this. I mean, I feel so warm here. I was the first to get food and no one judged me. In fact, they encouraged me to eat more food, and I'm gonna go home with a goodie bag for my wife, because it's really for me, but it's for my wife, you know. But I'll talk a bit about what we really are here for. We really want to create the first interventional pulmonology fellowship program in Ethiopia, because there's a significant need for advanced bronchoscopic and pleural procedures. We've heard a lot about what Global Health Equity Partners is all about. It is a nonprofit organization with a deep passion for promoting healthcare in underserved and resource-limited settings. And how the way they get this mission to come to life is by these three foundational pillars: education, partnership, and humanitarian support. So we want to educate the people on the ground, because you have to do that. You teach a man to fish, you feed him for life, right? So that's our goal. We want to educate the first IP fellow there in Ethiopia. Partnership is paramount. We need to collaborate with local institutions, governments, and global health leaders in order to amplify our impact. You know, multiple organs make up a system. In order to have valuable reach, we have to partner with others. And humanitarian support, it goes both ways. You know, we're asking you guys to donate, you know, things and your time and your talents, so that we can give it back to the people that need it. But in order for a nonprofit to grow, we definitely need to have that humanitarian support in kind. So even though Beth is a pulmonary critical care medicine fellow and her husband is a respiratory therapist, why are they focusing so much on pulmonary diseases and need for advanced pulmonary procedures? Well, there is a significant burden of respiratory disease in Ethiopia. And we'll focus a bit on tuberculosis because, I don't know if you've heard in the video that just played, there's a significant issue, both with diagnosis and treatment and the long-term sequelae of the disease. So Ethiopia is among the 30 highest TB burdened countries in the world. And even though we know that tuberculosis, pulmonary tuberculosis, can be very destructive and contribute to significant morbidity and mortality, the long-term sequelae, termed the post-tuberculosis lung disease, is pretty burdensome as well. Some 50% of TB survivors will actually develop chronic lung disease. And the disability-adjusted life years loss post-TB is 58 million. So that's 58 million healthy years lost globally from this burden of disease. And we're talking things like airway stenosis, pleural disease, which is the area around the lung, and cancer. Lung cancer rates have also significantly increased in Ethiopia. There's north of 120 million people in Ethiopia, but they don't have not one interventional pulmonary training program. So there's a significant mismatch there. 120 plus million, but only 18 pulmonologists. So there's definitely a need, and we're really trying to fill this gap. So what about the advanced procedures? It allows for prompt diagnosis. The quicker you can diagnose something, the quicker you can treat it. And the procedure itself can be treatment modalities as well. Without the trained specialists, patients often go undiagnosed and untreated. So Beth, Dr. Toma, she did a needs assessment as a part of her fellowship research. So I just kind of stole some of her data. St. Paul's Hospital in Addis is a 700 plus bed hospital that serves 200,000 patients per year. They have a 5 million patient catchment population. 75% of those patients get their care completely free. And she surveyed about 90 physicians there. What she found was that 50% of the trainees said they had actually never held a bronchoscope. About 70% of the faculty said that there was actually no formal bronchoscopic curriculum ever. And 70% stated that there was no formal pleural procedure training. But despite that, they're all very motivated. They all want to do this. So 100% of them are ready to get the ball rolling, whether it be in person or simulation-based training. Another major gap that was identified is the lack of equipment. So about 45% of respondents said there were limited equipment available, which made advancing care difficult. That combined with the lack of training are the two major barriers that we believe are very solvable. So this is the model, train one, transform many. We're here asking if we can get enough money to train just one physician to be the interventional pulmonology fellow in Ethiopia, who will then subsequently train others to kind of sustain advanced pulmonary procedures going forward in Ethiopia. So we have this train the trainer model. Every graduate will become the next program's mentor. So you have a pointer? Oh, there. So you place the seed money, you fund this person here who is going to be trained, and in about 5 years, the hope is that that person will then train 5+ future fellows, thereby impacting hundreds of lives, thousands of lives. Our goal is $60,000. Hopefully by now this has moved the needle a bit. But you know, whenever someone asks me for money, I ask where's it going to. This is what the money is going to. $25,000 will be the fellow stipend and living expenses for that year. As we heard from Dr. Yaman, it's tough to take time away from your regular job, especially when not being compensated significantly. So we want to make sure that they're covered. Another $20,000 will go to equipment and procedural supplies. $10,000 will go to faculty mentorship and bringing them back here to the United States for more hands-on advanced teaching. And $5,000 will be to build a simulation lab and to develop curriculum. Now, if we can get 250 people to each agree to donate $20 a month for a year, $20, that's cheaper than your Netflix subscription, right? We will be able to meet this goal. Here are some of our equipment wish lists, where there's bronchoscopic equipment such as flexible bronchoscopes, pleural procedure equipment like thoracentesis kits and in permanent indwelling pleural catheter kits, airway ICU equipment such as capnographs, or just anything to help with simulation training, whether it be mannequins or a bronch simulator. We're hoping that if you have some laying around in your respective facilities, collecting dust. I know in our pulmonary fellows office, we have a lot of stuff that, you can just sneak into a bag and send off. I'm not condoning anything, but I mean, they can be put to use. And this list is, Beth has it, and if you guys want it, you can get it. And we just want to emphasize with this slide that this is something that's going to be very sustainable, our hope is. And that 4+ years, we have scaled this program to expand beyond Ethiopia to other cities, right? Other countries. Ethiopia, we want to be to set the model for sub-Saharan Africa. And this is the QR code to donate. Like I said, our goal is $60,000. And you know, it's beyond donating the money. I mean, you guys are here, you're all passionate about it. It's really about impacting the lives of so many. I was very moved by a lot of the stories by Dr. Iman, in particular about the pediatric oncologists who years later, you know, we have so many oncologists now. So we don't have any interventional pulmonologists in Ethiopia right now. I'm hopeful that in the next few years, I can come back here and say, hey, we have 3 or 4, and we have advanced this care and filled this gap. Thank you so much. I appreciate your time. Don't let me forget that.
Thank you. As the last part of our program, I would like to invite Mona Atoma to share with us the winners of our silent auction. And hopefully many of you will be able to take some beautiful items with you home tonight from today's very memorable dinner.
Will I speak?
Yeah.
Hello?
Microphone.
Go ahead. You can start. Okay. Hi everyone. We're gonna announce the winners for each painting or all items on the auction. Starting off with the tropical bloom painting, which Gabriella Daniel has won. Get a round of applause. Okay, next is the painting of Quiet Strength, won by Hewott. Thank you. Okay. Okay. Excuse me. Okay. The next winner is for the Ethiopian coffee ceremony mini collection is Halima B. I like this outfit. This outfit. Be careful. Yeah. Got it. Okay. Thank you. The next winner is for the Amharic alphabet mug, won by Tyreek Noah Neon. I'm sorry. Thank you. Oh, I don't need that. Thank you. I give the paper. I will. For the traditional Ethiopian Jemina coffee pot, we have Vierki Ibia. You got it.
Oh, that's adorable.
For the next winner, we have the Ethiopian scarf gray alphabet, won by Kirube. Thank you. We have the Ethiopian scarf green and gold, won by Dile Oh, I'm sorry. The mark is very thick, so it's kind of hard to read it. D. Thank you. The mark is thick. Thank you so much. For the next one, we have the Ethiopian scarf, white, green stripe, won by Joanna Brio. Okay. Thank you. For the Ethiopian scarf, white, red stripe, we have Lena. Thank you. For the Ethiopian scarf, yellow alphabet, we have Tizitar. Thank you. For the Ethiopian scarf, deep blue, we have Virgi. Cut scarf? Do you want it? There you go. For the next one, we have the Ethiopian scarf, bottom blue. Also won by Virgi. You got it. One item. Okay. For the next one, we have the handcrafted Quran wall decor, won by Josh B. There you go.
We'll do final remarks after this.
For the last one, we have the Ethiopian hand-woven wall decor, won by KA. And this was KA. Okay.
So log into the website to volunteer wherever there's an option for local and international opportunities. Donate and sign up
Thank
for
you.
all the training in the future.
Okay.
Thank you so much for everyone who participated in the auction and everyone who could be here today. We appreciate you a lot. Huh? There's more? Huh?
I think this one's left behind.
Oh, they were?
Yes. It started
the
with
mic.
$30 each. Like $30, $30.
Anyone wants
And now
it?
for the first one, for this one. 30? Okay.
Great job.
You got them somewhere from there and somewhere there.
Yeah?
You got two people. You got two people.
Trying to
raise it up. 60, ask for 60.
Don't they have to like go like 31, 32?
Going once, going twice.
መቶ ይሄኛው 30 I'll go Silsa for this one. Silsa, mental. We're doing two at the same time. Hold the similar thing. 65. 65, okay. 65, mental, 65. Sorry, I'll do mental for this one, I'm sorry. Mental. What does mental mean? 100, sorry, 100. For both? No, for one. Oh, for one. So, yeah. It's confusing. I know. But we're doing it, because of the time. And it's the last one. Rapid fire. Yeah. 100 for each. Anybody? 100? 110.
Whoa! Yeah, it's right here. Do you need it?
Oh, you're wearing orange.
I'm wearing the other one. Okay.
All right, for this one. 1, 2.
All right, so.
Alright, 120. 120. 2. 150. 152. 155. Oh my goodness gracious! 150.
Thank you. Again, we thank everybody for your generous participation in the auction, and we hope you will go home with something beautiful tonight. With that, I will go ahead and conclude the program. On behalf of our team, we are incredibly thankful for everybody's participation today. We hope that we have shared with you our plans for the coming time. And again, we appreciate your feedback and thoughts as well. And thank you again for your generous support. I would like to remind everybody that we do have additional resources on our website. These include opportunities to volunteer, your time, your resources, or any medical equipment you have lying around. And we hope that you will continue to connect with us after tonight. This has been an incredibly, we learned a lot in today's journey. And also we invite you to continue with us going forward. This has been a very energizing night, and I hope you feel it as well. Thank you very much. And with that, we wish you a good night. Thank you.
Just so they can see.